Okay, everybody. Thank you for being here today for the Michigan Opioid Collaborative's Buprenorphine for Pain in the Setting of a Terminal Disease webinar. My name is Tim Hudson, and I am a behavioral health consultant for the Michigan Opioid Collaborative, covering the northern Michigan 21 counties, as well as Wayne, Oakland, and Macomb County. If you haven't done so already, please make sure you sign in the chat for attendance purposes with your name, where you work, and your email address. And please place yourself on mute. If you have questions that you'd like us to address with the presenter, please post that in the chat and we'll make sure we have those addressed. As you see on the screen here, we have the QR code for credits. Please make sure you complete those by Saturday, August 5th at noon. That's when the link will expire. We will send the PDF version of this, or post the PDF version of this in the chat throughout the course of this webinar, as well as send in an email to all those who attended later on today. So to begin, I'd like to give a brief overview of the Michigan Opioid Collaborative. We are an interdisciplinary team supporting providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders throughout Michigan. Michigan Opioid Collaborative is grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer same-day consultation services to help provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case questions related to treatment and management of substance use disorders. Michigan Opioid Collaborative offers quarterly introduction to buprenorphine trainings, as well as webinars on a variety of educational topics such as addiction, stigma, and substance use topics. We have a hepatologist on our team who offers Hep C treatment consultation within 48 hours, facilitates a biweekly case consultation webinar to review cases with providers, and has developed a 3-part webinar series on Hep C treatment. We've also created toolkits to providers to have more resources when treating patients with multiple substance use disorders. And so with that, I'd like to introduce our speaker today, Jane Shargat. Jane was a cardiology ICU RN for 7 years at the University of Chicago before going back to medical school at Rush Medical College. Jane went on to family medicine residency at U of M and completed her palliative and hospice fellowship, also through University of Michigan. Jane has stayed on here as faculty and currently splits time between the inpatient palliative care service, outpatient primary and palliative care clinics, and teaching medical students through the medical school doctoring program. And with that, I'll turn it over to Jane.
Thanks, everybody. I really appreciate you guys letting me be here and talk a little bit about buprenorphine for cancer pain in patients with terminal illness. You know, this is a place that I feel is rapidly changing in my field in palliative care. I take care of people who have terminal disease all the time. And I think we're transitioning the way that we're approaching it. And so I'm really excited to share this with everybody. It's going to be a case-based presentation, so hopefully this will be not horribly dry for everybody. All right, so I don't have anything to disclose to anybody today. Let me see here. And okay. So I'm going to present today, initially just, most of you guys are fully aware of this, but a brief buprenorphine mechanism of action summary. And then we'll move into my 3 cases. So the first one, we'll talk a little bit about buprenorphine and cancer pain, and then focusing on buprenorphine as a first-line pain management, and then the crossroads of palliative pain management and substance use disorder management. So buprenorphine's mechanism of action, the 4 main opiate receptors are the mu, kappa, delta, and ORL1. The mu receptor is the receptor that almost all full agonist therapy, this is where they act, right? This is the analgesia receptor. For buprenorphine, it partially agonizes. That's why we're called a partial agonist. And what it does is it gives great pain relief, but at a threshold. So at a certain dose, we don't get much more bang for the buck when it comes to pain relief. And we'll talk a bit more about that in a minute. But the other big piece about that partial agonist mu receptor response is the fact that it has less respiratory suppression, which is super helpful in a lot of our patients as well. The kappa receptor is an inverse agonist or an antagonist. It releases when it is activated by the buprenorphine molecule, it decreases the dopamine release in the nucleus accumbens, and that decreases the addiction and abuse potential for buprenorphine in comparison to full agonist therapies. And it also acts as an indirect NMDA antagonist, which then also decreases hyperalgesia. It counteracts the centralization of chronic pain, and it can also make this medication moderately neuropathic pain effective, which is super helpful for our patients who have complex cancer pain. The delta receptor is antagonized by buprenorphine, which decreases constipation. And then the ORL1 receptor is a more unique receptor for buprenorphine in comparison to the opiates, full agonist opiates. And that causes a slower onset of tolerance when you're on the buprenorphine for a long period of time. This slide is from a colleague of mine, Dr. Kyle Quirk, so I just want to give him some credit, but I know that this is kind of all over the place as well. I love it. You guys have probably seen it before. I'm just going to highlight a couple things. That for me, the piece that I focus on is the analgesia and how when it transitions away from good pain response. So what we're looking at here is the dose. So when you give buprenorphine, as you increase the dose, you increase the amount of receptors that are occupied by that buprenorphine molecule. As you increase the dose, as you increase those receptor occupied, you change the effect. So the best pain response happens around when you have 5 to 10% of those receptors being occupied. And then we start to transition away from pain once we start to hit that 50%. And that's starting to inhibit craving of other opiates. And then at 80%, we block the subjective effects of the misused opiates. And so when we're thinking about buprenorphine for pain management, we're looking at the sweet spot between microgram dosing all the way up to 6 to 8 milligrams in a total daily dose. And that's when you're going to get the best bang for the buck for pain management, because they are occupying somewhere in between like 5 all the way up to 50% of those opiate receptors. Around 6 to 8%, that's when, or 6 to 8 milligrams total daily dose, that's when we're starting to transition into substance use disorder treatment dosing. And those are great. It just doesn't give us more pain benefit. And that's what we're talking about today. So my first case is going to be focusing on evidence for buprenorphine in cancer pain. This is one of my patients, Ms. KT. She's a 55-year-old lady. She has a new diagnosis of anaplastic thyroid cancer. When she presented to the hospital, she was presenting with pain in her neck. It was radiating down her left arm into her fingers and described it as a burning, stabbing pain, and in her neck, a sensation of painful fullness. Her imaging showed a thyroid mass that was invading her left neck, and it abutted her brachial plexus, which is the nerve roots that kind of go down into our arms. And it was also causing compression of her trachea and her esophagus, and it was resulting in positional difficulty breathing and difficulty swallowing, particularly solids. So she was rating her current pain as quite severe, 7 to 9 out of 10. And her current pain regimen was oxycodone, 5 to 10 milligrams every 4 hours, which would bring her pain down to about a 5 for a couple hours. And she would really take it sparingly. So she wouldn't take 10 milligrams every 4 hours. She was usually averaging between 30 or 40 oral morphine equivalents in a day. She was also taking Tylenol and gabapentin. And when palliative care meets with a patient, we talk about patient symptoms, but then we also focus on patients' preferences of care, trying to get an understanding of what they're hoping from their medical care and from their medical teams. And as we're going through our discussion, some things kind of became more obvious. her conversations had been really focusing on what was happening in her body because of the cancer. And she was really worried about the fact that she was starting to have trouble breathing and trouble swallowing. And the team was talking to her about potentially needing a tracheostomy and potentially needing a G tube for feeding. And those things mean that she won't be able to swallow pills very well. And she will not be able to potentially talk as well as she can now. So there's a lot of worries in her mind. And she also is concerned about avoiding sedation. So the oxycodone right now is helping with her pain, but it's really causing her to be very drowsy. And that's impacting her ability to understand all of these complicated discussions that are happening around her and to her, revolving around her disease-directed options. So she's getting a little bit worried, and she's hoping that we can do something better. Additional considerations that we were having as we're thinking about her pain management is, she's responding to the opiates, meaning that her pain is responding, is appropriately being treated by her opiates. And she's also having some nerve pain symptoms, which potentially could be benefited by that buprenorphine as well. So why do we think we can use buprenorphine for cancer patients anyways? There's 3 big studies that give us substantial data for being able to use this. So the first one that I looked at was a meta-analysis. It was encompassing 16 studies. I want to just share the takeaways. The takeaways were buprenorphine is better than placebo, or in these studies, it was superior to the comparison opiate, or it was non-inferior to the comparison opiate. The next study showed was studies that a systemic review that reviewed both chronic as well as cancer pain. And those big takeaways from that systemic review was buprenorphine had less side effects, it had less drug interactions, and again, it was found to be non-inferior to the opiate pain management as far as eliciting pain response. And the last study was an open label clinical trial with hospice patients outside of the US. They were using the buprenorphine transdermal patch at higher doses than we have here. And they were trying to see, could we use usual doses of things like morphine or oxycodone for breakthrough pain in these patients who had a little bit of a higher dose of buprenorphine? And they found you could use usual dosing of those full agonist opiates just as easily as you would if you were using a long-acting full agonist in comparison to the long-acting buprenorphine. So just to kind of summarize that up, what basically we're saying is buprenorphine is at least non-inferior or equivalent to full agonist therapy for pain relief in cancer treatment and terminal pain. In some cases, it's really superior in the sense that it has less side effects, it has less drug interactions, and you can easily treat breakthrough pain even if somebody is on buprenorphine for long-acting pain relief in these patients. So what are some of the factors that I think about as a palliative care doctor when I'm thinking about buprenorphine for cancer pain? So the first thing is prognosis. I try to think, is this patient going to be with us for a while, or are they going to die soon? If they're going to die soon, if their prognosis is quite short, I think that buprenorphine isn't probably the right pain medication for those patients. Buprenorphine transitions typically take a few days. If we're using the transdermal patch, it's going to take at least 2 to 3 days for it to actually act in somebody's body, and takes about 5 to 7 days to get full relief. So I really hesitate to use, and that transition, if we're using either the buccal therapies or the under the tongue sublingual therapies, those also usually take a couple of days to get to a therapeutic dose. So from my perspective, if you have a short prognosis, really think twice before you're using buprenorphine for that. However, if you have a longer prognosis, if you're going to be with us for months, maybe even years, and you're going to have stable pain or pain that isn't expected to change rapidly, certainly buprenorphine is that first thing that I'm always thinking about now. It has less tolerance. So what I'm hoping for is that these patients, once we get to a therapeutic dose, I don't have to continually increase their dose to get the same adequate therapeutic response. And then we'll talk about other benefits in a moment. But these patients are typically ideal patients for buprenorphine. I also think about the risk for rapidly changing symptoms, either if they're going to be feeling better or feeling worse over the next couple of days to weeks. Again, coming back to the fact that it's going to take a while for us to transition those medications to being therapeutic. And so if I think something's going to change quickly, I'd rather them be on full agonist therapy, and maybe once they stabilize, reevaluating whether or not we want to use buprenorphine. And other risk factors that might actually tell us, hey, this is going to be a good candidate for buprenorphine. The first one is liver or renal failure. So kidney and liver failure. Buprenorphine is actually metabolized and eliminated by our gut. It's not metabolized through your liver, and very little through our kidneys, which means if you are in liver failure or kidney failure, we don't have to change the dose. We don't have to decrease the dose. We can also safely give that in those patients without worrying about rapidly accumulating toxicities. And additionally, it's not as easily dialysable, meaning that if you send them to dialysis, you're not going to end up in a pain crisis because you just got rid of all of their pain medications. If somebody has dysphagia, if they're having trouble swallowing, or they're just completely unable to take any oral medications, this is a great medicine, as it's typically delivered either through the skin or buccally at the cheek or under the tongue. You don't have to swallow it, and it still gives long-acting relief. If somebody has a high risk for respiratory compromise, it's much less likely to cause respiratory failure and death in comparison to full agonist therapies. If somebody has gastroparesis or slowing down of their gut, this medication is less likely to further worsen that symptom or that syndrome. And so it's much easier tolerated for those patients. And if patients have polypharmacy or taking a bunch of medications, this may be a medication that has less drug interactions. One thing that I think about is full agonist therapies actually are serotonergic. They cause serotonin increase in our body, and that can actually interact with things like antidepressants or other pain medications and increase risks that come along with too much serotonin, something called serotonin syndrome. That's one of many things that that I think about when I'm trying to think what is the safest medication that will give somebody good pain relief. And there's others we can keep on talking about, but those are the main ones that I think about. So when I also think this is a good graph, I just like to go over it. I'm sure you guys, a lot of you have seen it, but this is a rat study that compares one of the more typical full agonist opiates, fentanyl, to buprenorphine. So on the bottom axis, this one right here, we're talking about dose. So as the fentanyl dose goes up, the respiratory rate goes down to 0. So the higher the fentanyl dose, the more respiratory suppression you have. With buprenorphine, as your buprenorphine dose goes up, you actually have a threshold. You don't suppress somebody's respiratory rate below 10. So the likelihood of death being caused by buprenorphine by itself is low. And so this is a big deal, obviously, to most people, but to us really important as well. So the other thing that I think about is other medications, right? As soon as you put other full agonist opiate therapies, as soon as you put benzodiazepines, this kind of goes out the window, but it's still important to think about as far as the bigger picture safety profile of medications you're giving. So buprenorphine dosing. The first thing that I think about as a prescriber is I think about how much medication are they using to get to a good pain level at baseline. So when I'm thinking about that, I think about transitioning everything to what we call oral morphine equivalents. So how many milligrams of oral morphine are they taking in 24 hours? For the patient that we are seeing, she has about 35 oral morphine equivalents that she's taking in 24 hours. Then I start to think about, how am I going to give that to somebody? Am I going to give it to them with a transdermal patch, a buccal film, or a sublingual tab? Because she's going to have probably a G tube for her administration of medications, she's already having trouble with pills, And additionally, we're worried that she may have radiation to her neck region. I would like to first consider a transdermal patch for her. So the transdermal patch, one of the main brand names is Butrans. So it comes in a variety of strengths, anywhere from 5 micrograms an hour all the way up to 20 micrograms an hour. And each of those are applied about every 7 days. So it's a very easy medicine. People don't have to keep dosing every 4 to 12 hours. It's not something you have to think about all the time. It's nice and long acting. The first thing that you do, remember, is get that how much medication are they requiring? So that total oral morphine equivalents. If somebody is taking less than 30 oral morphine equivalents in a day or hasn't ever been on opiates in the past or opiate naive, then you start on a 5 microgram patch. If they're taking 30 to 80 oral morphine equivalents in a day, that's 10 microgram patch. And then if you're over 80 milligram oral morphine equivalents, that's a 20 microgram patch. But honestly, I would probably start thinking about another way of delivering buprenorphine at 80 micrograms or up. So guidance for the patch. For people who are starting this medication, if you look this up, what they're going to say is that you should get their oral morphine equivalents lower, so less than 30 oral morphine equivalents before you put on the patch, or let them be off of any opiates for at least 12 hours. In the practical sense, this isn't necessary. The first reason is that these are microgram doses. It's incredibly low. This is the likelihood of precipitating withdrawal on this very, very small dose is practically zero. And so just putting it on and continuing their home dose is perfectly fine. The other reason is this patch is going to take about 2 to 3 days for the patient to actually start to feel the buprenorphine effects, and 5 to 7 days before you start to feel the full effects. So it's going to be such a slow onset that it's also not going to precipitate any sort of withdrawal for a patient. So again, no need to hold the opiates. You can continue at their current dosing, and you give them that guidance that we're going to put it on today, but you're not going to feel that effect for at least 2 to 3 days. We typically don't recommend going up in a dose when you're using that transdermal patch for at least day 5, because again, you're not going to feel that full effect until day 5 or 7. So you don't really know, do I need a higher dose until that point in time? So case 1, coming back to our patient, we started her on a 10 microgram patch, given how much opiates she was needing. We continue the oxycodone 5 to 10 milligrams every 4 hours as needed. We optimized her other pain medications. And on day 3, she was taking only 1 or 2 doses of oxycodone. She was having substantially improved pain management. And more importantly, she was more functional. She was less sedated, and she was more able to participate in the discussions for her treatment that were needed. So case number 2 is buprenorphine as a first-line pain management. So this is about my patient AM. She's an outpatient palliative care patient of mine. She's 58 years old, and she has a diagnosis of metastatic lung cancer. She's currently on palliative chemotherapy, and she has received radiation treatment as well. Her pain is located over her thoracic spine, and she has a radicular component, or a nerve component, that is coming around and wrapping around her left chest wall. Some of the other areas that she's in pain is over her low back and in her pelvis, and all of those areas correlate to areas that she has known metastatic disease in her bone. She has received palliative radiation to those lesions, but they've only moderately improved her pain, and actually now her pain is progressing. So her patient preferences is that she avoids what she calls narcotics. She's had morphine in the past. She did not like the way it made her feel. She's not interested in having, what she labels as narcotics as her pain management. She really wants to avoid sedating medications. She's continuing to work full time through all of this treatment. She finds her job really fulfilling. She has to drive. She has to be very alert, and she wants to avoid any impairment to her cognition. And she wants to avoid addiction. She has a son who has substance use disorder. She really worries about her own risk. She worries about the risks of bringing in opiates into her house where her son lives with her sometimes. She doesn't want to have that burden on her. So we initially tried the buprenorphine patches. We started on 5 micrograms an hour because she's never been on regular opiates in the past. And we escalated with time all the way up to 20 microgram an hour patch. It was good, but it was really causing a lot of skin irritation. It didn't stick very well for her. And so we use often a little bit of topical steroid on the skin. We have the patients put it on about 2 hours before they apply the patch if they're having some mild to moderate irritation from the adhesive. They wipe that area down right before they put the patch on and then put the patch on. It seems to work pretty well, but for those who really have persistent and more severe symptoms, sometimes that's just not enough. And it wasn't for her. So as far as side effects go, she had a little nausea whenever we put on a higher dose or that initial patch, but that usually resolved within 48 hours. And overall, she tolerated it well and had good response. But it wasn't completely great. So we decided that we were going to go to the Belbuca films, which are the lower dose buprenorphine films. They're in micrograms. So these are similar to the Butrans patch. They're both dosed in micrograms, not milligrams. They're for pain, not substance use disorder. And at these initiation doses, I really don't worry about holding or reducing their patient's full agonist therapy. And they're not at the initiation doses here, they're not going to be strong enough to cause any potential withdrawal symptoms. So with patients, again, you're going to want to find their total dose, their total daily oral morphine equivalence dose, and start that transition kind of following these guidelines. So if they're less than 30 oral morphine equivalents in a day, or if they've never taken opiates before, you'd want to start at 75 micrograms once a day or twice a day. And then you want to step it up if you're at a total daily dose of 30 to 89 oral morphine equivalents. You'd start at 150 micrograms twice a day. And if you're taking 90 to 160 oral morphine equivalents in a day, you'd want to do 300 micrograms twice a day. If your patient is taking over 160 oral morphine equivalents in a day, you might want to think about other formulations. And I imagine some people here who have seen patients, they're like, oh my gosh, 160 oral morphine equivalents in a day. It maybe shocks some people, maybe it doesn't shock other people. In my world, that's not shocking. So I appreciate that there's a whole bunch of people coming from all over the place. So when we have these higher doses, right? So when we're looking at 30 or higher, 160 oral morphine equivalents in a day, most of the time people are taking a long-acting medication, oral morphine, or like Aniscontin or oxycodone or something else that's a long-acting, and then treating breakthrough pain with short-acting. So briefly, what we typically will do is we'll take our last dose of your long-acting full agonist opiate, and when the next dose is due, that's when you start your Belbuca films. So we transitioned her from the patch, we transitioned her over to the 300 microgram films twice a day. And then we increased because she wasn't quite where we would want her to be at yet. She's on 450 micrograms twice a day at this point in time. She's getting to the right spot. We're still dose adjusting, but this is where she's at this point, and pain is getting more and more tolerable. So our case number 3, this is kind of the crossroads of cancer pain management and substance use disorder management. So this is patient JR. He's a 65-year-old gentleman. He has a diagnosis of metastatic lung cancer. He's had a resection. He's had multiple rounds of systemic treatments, and he's had radiation therapy. He's now presenting to the hospital with a recurrence of his metastatic disease. He doesn't have any further disease-directed treatment available to him. And his metastasis is now to multiple bones, to bilateral lungs. It's kind of diffusely over his body. When he presented to the emergency room, he had severe protein calorie malnutrition. He was very weak. He was functionally limited, not only to the weakness, but because of severe pain because of his widespread bony metastasis. So social background for him, his caregiver is his daughter. She actually was living in Florida for the past several years, hadn't seen him very frequently, and decided to move back to Michigan and leave her life in Florida to be his full-time caregiver when he was admitted for this hospitalization. The patient himself is a retired musician. He had a really full life and lots of great stories. And he has a history of polysubstance use disorder. He's been in remission now for about a decade. But for both him and his daughter, they're really anxious and worried about how are we going to manage his pain and prevent relapse into addiction again. And they really want us to consider what they would call a safer alternative to preserve his ability to get good pain relief, but then simultaneously, hopefully reduce that risk on him. So he presented in the ER with pain crisis with all of this. And when he was admitted, he was started on a hydromorphone or dilaudid PCA. When I first met him, he was taking about 500 to 600 oral morphine equivalents in a day using that PCA dose, which is quite high. And we recommended that the team give him something called ketamine, which is a medication that goes through your IV and can reset your opiate pain receptors so that they're more responsive to the opiates and decrease your need for opiates. And so after 3 days, his requirements were decreased by almost 50%. And he was at 300 oral morphine equivalents in a 24-hour period. And his pain was well controlled. So it was a time for us to start considering transitioning him to an oral pain regimen or something that he could potentially go home on. So how do we transition somebody from one kind of oral full agonist therapy at high doses to buprenorphine? And this is something that I do both in the hospital and outside of the hospital, but it's much, much easier if somebody's in the hospital. And we usually use something called microdosing. And when we do that, we are doing that on patients who aren't good candidates for those other two microgram dosing forms. So not good candidates because of the need for opiates for the transdermal patch, or for the lower dose buccal films. So instead, we're going to use the buprenorphine combination of buprenorphine and naltrexone. Typically, we use the Suboxone films or the off-brand. This is when we have somebody who's over 160 oral morphine equivalents in a day. So the way we start this is we start a quarter film twice a day. That is a half of a milligram of buprenorphine twice a day on day 1. On day 2, we're going to increase that to a half of a film twice a day. That's going to be 1 milligram of buprenorphine twice a day. Then we're going to increase to a half of a film 3 times a day, or 1 milligram of buprenorphine 3 times a day. And day 4 and beyond, we're going to increase by half of a film every day until somebody has adequate analgesia. Again, if you're looking for pain alone, your maximum daily dose is going to be between 6 and 8 milligrams of buprenorphine for pain. For this person, I'm just going to talk a little bit about what that looks like when we're transitioning from somebody who has high use on a PCA, a patient-controlled analgesia. That's when your patient is administering their pain medications through the IV. They typically have a continuous rate that's slowly giving a low dose continuously, and then an additional dose that they can give themselves with a button. When we're doing that for people who are managing this on the inpatient side of things in the hospital, what we typically will do, depending on how much they're using, we would drop their continuous rate by 50% and start that quarter film twice a day. And on day number 2, when you're increasing it to a half of a film, then you're going to discontinue that continuous rate and keep that button for a little bit longer as we're moving through the process. If this is somebody who is on pills already and is on a combination of long-acting full agonist therapy and short-acting full agonist therapy for breakthrough, then what you're going to do, depending on the dose, if it's quite high, I would still recommend dropping it by 50% for that initial first day quarter film. And then on your second day, just stop that. And the reason is these are patients who are being seen for pain crises. These are patients who we're treating for pain and not necessarily substance use disorder, but maybe they do have substance use disorder as well. Regardless, we don't want to precipitate a pain crisis here. And so we're really trying to make this as smooth and easy of a process as possible. And additionally, if somebody has a pain crisis in the midst of this transition because we didn't transition them easily enough, we're really going to probably make them not want to take buprenorphine, which may be an ideal medication for them. And now you are eliminating that as an option for them because they found it to be too difficult to tolerate. So we're really trying to make this as easy on them as possible. Now, what do you do if somebody has active substance use disorder and is currently managed on substance use disorder dosing buprenorphine? The first recommendation is to continue their total daily dose that they're already prescribed. But we recommend that we split those doses. Instead of dosing twice a day, split it into 3 or 4 times a day dosing, because that pain management response from buprenorphine is 6 to 8 hours. That's how long it lasts for. So if you're dosing at 12 hours, you're going to get a period of time right in the middle there that they're not getting as good of pain management, and they're going to start looking for other ways to manage their pain. By doing this, we've found that you are actually going to decrease their breakthrough pain management needs. You're going to improve the likelihood of adequate pain relief, and you're going to hopefully reduce the prevalence of substance use disorder relapse. Now, for breakthrough pain, right? So if the patient is receiving over 8 milligrams in a day dosing, which is most likely with most of our substance use disorder treatment patients, they're going to require a more potent full agonist therapy for breakthrough pain management. So that's typically going to look like higher dosing of oral hydromorphone or Dilaudid, and in very, very rare cases, for people who are on hospice therapy, possibly IV fentanyl. For our patient, we transitioned him initially to the buprenorphine using microdosing. We eventually got to a dose using 2 milligrams 3 times daily, and he had a half of a film or 1 milligram of buprenorphine that he could use twice a day as needed for breakthrough. And he did excellently. He felt that he had good pain management. His functional status improved a little bit. But eventually, with a lot of discussions with his cancer team and with our team, he felt clear-headed as well, sorry. He decided to transition to home hospice, and recognizing that his symptoms were going to probably change and may need a little bit more flexibility with that pain management dosing, we liberalized the breakthrough pain medicine over to oral Dilaudid, which he could then take more frequently and increase if he needed. So that's actually the end of my presentation. And these are my references for today. And I wanted to take a quick moment before I answered any questions to thank a bunch of my colleagues. So my palliative care team, but most specifically our pharmacy team. So Dr. Mike Smith, Dr. Madison Irwin, and Dr. Kyle Quirk. They've really helped lead the charge for our palliative care buprenorphine train. And I really owe a lot to them as far as helping me learn and helping me and my team take good care of our patients. And even more, I thank my family that they keep me at least partially sane when they're not the ones driving me crazy. So if anybody has any questions, I'd love to hear them and hopefully answer them.
Thank you for that. If anybody has any questions, please feel free to unmute yourself, or if you're more comfortable, please feel free to pose the question in the chat.
Hi there. I just wanted to comment. Oh, go ahead, Mary.
Hi, Mary.
Oh, hi. I'm just wanted to ask about what about people who have terminal illness who end up having surgical interventions and things that can be really complicated. I give anesthesia for a living. So is there a resource that would be helpful for that? Or do we just look at oral morphine equivalents and kind of?
So are you talking about what do we do if they're on buprenorphine to manage their anesthesia? Can we give anesthesia for patients who are receiving buprenorphine? Is that the question,
Well,
Mary?
we used to hold buprenorphine. Now we just continue them on their dose.
Mm-hmm.
But in that circumstance, if you're going to have additional pain, would you then just add some kind of an oxycodone or something for a few days? Or would it be better to go up on the buprenorphine, or what do you think?
So this is where the art of pain medicine comes in, right? So I'd say there's all of those answers are correct. I've used buprenorphine as a breakthrough for some patients. I've used Dilaudid as breakthrough. Typically, I start to think about Dilaudid as a breakthrough pain management if we're heading north of 4 milligrams of total daily dose. It just seems to work better. But under that, I often am using, it depends on the patient's kidney function and liver function, whether I'm using morphine or oxycodone, or maybe even Dilaudid if we're in full liver or kidney failure. But any of those would be great. I'd probably look first and see what have they been on before. Because the most important thing that I see when I see patients in the hospital is people not necessarily paying much attention to what did they require before this pain crisis to have good pain management, and underdose what they're giving. And you see, like, a lot of my patients have oral morphine equivalents that are over 150 milligrams in a day, which means that people may feel uncomfortable giving this, but we have to give at least what they're taking at home, and probably and then some, to manage a pain crisis or to manage pain over and above what their chronic pain management due to their disease is. So I think, Mary, if I were to say anything, is to first look at what they're already taking as breakthrough pain. Most of them will be on something, and then consider either giving it more frequently or at a higher dose. And sometimes that's a little bit of trial and error, giving a dose and see if it works, giving a higher dose, giving it IV. It really depends on the patient and how they're responding. Does that help?
Yes, thank you very much.
No problem. I think there was somebody else too.
Yeah, hi, Doc. Thank you for your presentation. And I know the setting, it's appropriate for palliative care, but I was curious about within the primary care space. I think Dr. Daniel Berlin did a presentation about introducing Bup in that setting where, I see a lot of Q4, Q6 regimen and whether there's patient adherence or not, but just plateauing. And I'm hearing some pain centers that are using the Butrans patch very successfully. Are you seeing more adoption in the primary care internal medicine space?
So yes, I would say. So where I practice, I'm at the University of Michigan, right? It's an academic a group, and we do a lot of teaching as far as buprenorphine goes. And so I think our residents are coming out much, much, much more familiar with buprenorphine and feeling really comfortable using it for chronic pain regimens. I will say, our attendings are slowly getting there too, the ones that aren't necessarily directly involved with resident teaching. And we're working on it. I see it more and more in the community, in groups that aren't necessarily part of like resident education. I see a lot more people being more and more comfortable using buprenorphine. And I think this is what we're going to see moving forward, right? I think we're going to see more and more and more chronic pain management when opiates are appropriate or have been chronically used, that we're transitioning them to the buprenorphine. And I agree with you. So I do primary care as well as palliative care. And with those patients of mine that have refractory symptoms or have, many, many reasons that they can't take adjuvant medications or non-opiates, a low dose patch can be a game changer for them. And so it's really, I found it incredibly effective. And the fact that tolerance is lower, and when you're using it on its own, it's much less likely to cause respiratory failure. Those are pieces that make me feel more comfortable using it for chronic pain. Okay. Well, it's been really lovely talking with all of you guys. It's been great to just see the diversity of people that are attending these meetings. And so I really appreciate being able to be here today.
Thank you all for being here today. And a reminder again about the credits, please make sure you complete those surveys by Saturday, August 5th at noon. And thank you again for being here. And we look forward to seeing you at the next event. Thank you, everybody. And thank you, Jane, again for being here today.
No problem.